In August of 2008, while I was attending medical school in the Dominican Republic, I responded as a volunteer rescuer to a bus crash that killed at least 18 people. The call did not feel like a textbook scenario. It was wreckage, heat, noise, blood, confusion, and people everywhere. Some were screaming, some were trapped, some were walking around in shock, some were silent, some were not moving at all. That first 60 seconds, standing in front of a scene like that, is where most people freeze because the brain is not built to sort that many patients at once. It is built to help the one directly in front of you. Today, I'm going to teach you the framework that lets a civilian or a medic, a cop, a teacher walk into chaos and start making order. Not because it makes the scene easy, it does not, but because triage gives you a way to decide who needs help first, who can wait, and how to save the most lives when there are more patients than rescuers. I'm Dr. Marco Torres. This is Talking TACMED, Episode 8. Mass casualty incidents are no longer a rare event in American civilian life. You have school shootings, concert stampedes, highway pileups, industrial accidents, natural disasters, active threat events at places of worship and retail stores. These scenes share a single defining characteristic: more patients than resources. The math has flipped. You cannot help everyone who needs help. You have to choose. Now, choosing is a skill. It's called triage, and it has a doctrine. And the doctrine is simple enough that a civilian can learn it in about 20 minutes. The tragedy of civilian emergency training is that this framework is almost never taught outside of EMS, fire, police, and military medical channels, even though the people most likely to be first on the scene at a mass casualty event are civilians. This episode hopefully fixes that. We're going to cover the START triage system, which is the framework used by virtually every civilian EMS agency in the United States. And by the end of this episode, you will know the 3 questions that sort any patient in any mass casualty scene into one of 4 categories in under 30 seconds per patient. Now, before we walk through the gates, I have to name a doctrine pivot this episode requires, because every prior episode of this show has taught the opposite. In single patient response, what we've covered in episodes 1 through 7, a patient who stops breathing gets immediate intervention, an airway maneuver, rescue breaths, compressions. In mass casualty doctrine, that flips. One rescuer doing CPR on salvageable patient is one rescuer not saving 5 savable patients. This is the single hardest pivot in pre-hospital response, and it's what makes mass casualty a different doctrine. It's not a scaled up single patient response. If you cannot make that pivot in the moment, the framework will not work. If you can, it will. START stands for Simple, Triage, and Rapid Treatment. The framework rests on 3 physiological gates, which are taken in strict order. Each gate asks a question. Each question can be answered with a yes or a no. The combination of answers sorts the patient. So let's talk about these gates. Gate 1, respiration. Is the patient breathing? If no, you open the airway with a single jaw thrust or a head tilt maneuver. If they're still not breathing, then they're categorized as expectant, meaning non-salvageable in a resource-limited environment, and you continue triaging. This is the hardest moment of the algorithm. You're walking away from someone who might be saved in a hospital, but cannot be saved by you right now in a mass casualty context without taking time away from other patients who are actively or savable. If the patient is breathing, but at a rate of over 30 breaths per minute, that is a sign of severe physiological distress, and they're categorized as immediate. If they're breathing at a rate of 30 or under, you proceed to gate 2. Gate 2 is perfusion. Is the patient perfusing adequately? Now, the civilian accessible test is the radial pulse check. Is there a palpable pulse at the wrist? Or the capillary refill test. So what you'll do is you'll press on a fingernail bed, release, and count. The color should return in under 2 seconds. If there is no radial pulse, or if capillary refill is greater than 2 seconds, the patient is in early shock, and they're categorized as immediate. If perfusion is adequate, proceed to gate number 3. Gate 3 is mental status. Can the patient follow simple commands? The classic triage command is raise your hand or squeeze my fingers. If they can follow the command, their brain is perfusing, their airway is open, they are breathing, and they're categorized as delayed, meaning they need care but can wait longer than the immediates. If they cannot follow the command, something is wrong centrally, and they're categorized as immediate. These three gates, respiration, perfusion, mental status, each takes seconds to access, and the result sorts every patient into one of four categories: immediate, delayed, minor, or expectant. And those categories drive every resource decision that follows. Now, one scope note that we need to know before we move on: these thresholds apply to adult patients. Pediatric patients use a modified algorithm called Jumpstart with different respiratory cutoffs, under 15 or over 45 breaths per minute, because a respiratory rate that signals distress in an adult is normal for a toddler. Jumpstart is covered in additional modules that we will be filming later on. For this episode, we're going to assume that all the patients are adult patients. Now, the National EMS Model Guidelines reference START as the foundational civilian mass casualty triage system, and it's the framework taught in federally recognized mass casualty programs and in most state EMS curricula. The four categories have universally recognized color code. So let's start with red, immediate. The patient has a life threat that can be reversed with limited intervention, severe but survivable bleeding, compromised breathing that responds to positioning, early shock. These patients get treated first, transported first, and receive the most resources per unit of time. They are the category that benefits most from rapid, organized response. Then you have yellow, delayed. The patient has serious injuries, but it's physiologically stable in the short term. A broken femur without severe bleeding, a significant burn that is not yet complicated by shock. These patients can wait 15 to 60 minutes, for example, for definitive care without significantly worsening outcomes. Green, minor. These are the walking wounded. These are the patients who can comply with simple commands to move to a designated area. Lacerations, abrasions, minor orthopedic injuries. These patients in an organized mass casualty response are often directed to self-sort by the triage officer, basically walking to a gathering point where they can be reassessed. And finally, you have black, expectant. These are patients who cannot be saved with the resources available. Now, in a normal single patient response, every one of these patients would receive aggressive resuscitation. But in a mass casualty context, devoting a responder and a ventilator and a helicopter ride to one unsalvageable patient may mean that several salvageable patients will go without help. The doctrine is emotionally brutal and ethically clear. In a mass casualty event, you do the most good for the most people, and sometimes that means walking away from someone. Now, in the window between scene arrival and EMS arrival, the civilian responder applies the algorithm, including the apneic after airway designation that drives the expectant categorization. That is the truthful answer to the scope question. The civilian categorization is a working categorization, and the arriving EMS commander confirms or revises it based on resources and the clinical judgment in the next phase. The civilian's job is to apply the framework correctly, communicate it cleanly, and hand off a clear operational picture. You're not making permanent care decisions. You are buying time and structure for the professional response that follows. Now let's go back to the bus crash in the Dominican Republic. This was not by any stretch of the imagination a clean classroom problem. It was a wrecked bus, injured passengers, bodies on the ground, people yelling in Spanish, bystanders trying to help, traffic, heat, confusion, and of course, limited equipment. I was there as a medical student and volunteer rescuer, which means I was not walking into that scene with a fully staffed rescue company behind me. I was walking into the same problem every first responder, civilian, off-duty medic, police officer, teacher, or volunteer faces in the first minutes of a mass casualty incident. Too many patients, not enough hands, not enough time. So here's how that first operational window has to look. 0 to 30 seconds. You take command of the only thing you can control, movement. You announce loudly and clearly. If you can walk, move away from the bus and go to that safe area now. So you point to a specific location, a wall, a tree line, a shoulder of the road, the far side of the scene. Doesn't matter. Do not say, everyone move. Say, if you can walk, go there now. That one command identifies your green patients right away. The walking wounded will self-sort. They're not ignored. They are moved out of the danger area and separated from the critical patients and, of course, held for reassessment. But they are not where your first 30 seconds go. In the next 30 seconds to 2 minutes, now you move to the patients who did not walk. You don't start with the loudest person. You don't start with the closest person just because they're closest. You start at one edge of the casualty area and move in order. Now, each patient gets the same 3 gates. Are they breathing? Are they perfusing? Can they follow a command? If they are breathing too fast, they are red. If they have no radial pulse or pulse capillary reflow, they are red. If they cannot follow a simple command, they are red. If they are breathing, perfusing, and following commands but cannot walk, they are yellow. If they are not breathing, you open the airway once. If they still do not breathe, they're marked expectant in that resource limited movement, and you move on. Now, that last part, that's the part people hate, and they should hate it. It should never feel casual, but in a bus crash with multiple patients on the ground, stopping to work one apneic patient while 5 salvageable patients bleed, suffocate, or go into shock is how a bad scene becomes worse. Now, in the next 2 to 3 minutes, your job is not to fix the whole crash scene. Your job is to create order before organized resources arrive. Greens are in one location. Reds are identified. Yellows are identified. Expectant patients are marked or verbally accounted for. Severe bleeding gets rapid control if it can be done immediately. Airway positioning gets done if it takes seconds. You're not doing prolonged treatment. You are sorting, making life-saving interventions only when they are fast, and building the first operational picture for EMS. Speaking of which, in the next few minutes, the first organized units will arrive. EMS, fire, police, military, whoever gets there first. And your handoff is direct. I have walking wounded over there. I have immediate patients here, here, and here. I have delayed patients along this side. I have patients who were not breathing after airway repositioning there and there. Severe bleeding has been controlled on this patient. I have not completed secondary triage. That briefing matters because in a mass casualty incident, a clean 20-second handoff can save more lives than a heroic 5-minute intervention on the wrong patient. This is the framework. 3 gates, 4 categories, 1 command to sort the walking wounded, 1 disciplined pass through patients who cannot walk. It's simple enough to teach the civilians and strong enough to hold up inside real chaos, including a bus crash on the side of the road with more victims than rescuers. And so, my friends, what are the 3 takeaways from this episode? 1, triage is a skill, and its core doctrine is 3 physiological gates taken in order: respiration, perfusion, mental statin. Each takes seconds. Each produces a clear answer. The combination sorts every patient. 2, the 4 categories: immediate, delayed, minor, expectant. These are all about matching resources to salvageability in a resource-limited environment. The doctrine is emotionally hard, but operationally correct. The single patient instinct is to intervene on every breathing problem inverts in mass casualty, and that pivot is the framework's center of gravity. 3, the civilian's job in a mass casualty is to apply the algorithm, self-sort the walking wounded with a single clear command, and hand off a clean operational picture to the arriving professionals. The contribution is worth more than the most individual medical interventions you could possibly perform. Now, in the next episode, we shift back from the macro back to the micro. 1 patient, 1 very specific problem: airway without a tube. What the civilian responder can actually do when someone's airway is compromised and an advanced provider is not yet on scene. It's a surprisingly short list, and it's surprisingly effective. I'm Dr. Marco Torres. This has been Talking TACMED. Stay ready, and I'll catch you next time.